I'm pleased to introduce our esteemed moderator this evening. Dr. Linda Russell is a rheumatologist and the Director of Osteoporosis and Metabolic Bone Health Center at HSS. She is also the Director of Perioperative Medicine here. In addition to the evaluation and care of patients, Dr. Russell leads a team of internists and hospitalists who deliver perioperative medical care to patients undergoing surgical procedures. Dr. Russell's practice focuses on osteoporosis and metabolic bone health, and she leads efforts to develop preoperative weight loss, diabetes management, and smoking cessation programs at HSS.
Good evening, everybody, and welcome to the role of bone health in orthopedic surgery. I'm pleased to introduce our panelists this evening for a discussion on why bone health matters in orthopedic surgery. Joining us tonight is Betty Chow, an HSS board-certified clinical specialist in orthopedic physical therapy. Betty, you want to say hi? We also have Dr. Alana Serota, an HSS internal medicine physician and a metabolic bone specialist. Dr. Serota? And we have Dr. Emily Stein, the HSS interim chief of the endocrine service and director of research of the metabolic bone service and an endocrinologist. Dr. Stein, thank you for joining us. We're very excited about this program tonight. So why should patients care about their bone health when they're having orthopedic surgery? They should care because if you have poor bone quality, such as osteoporosis, you may be at risk for perioperative complications. Some of these complications may include an intraoperative fracture when the surgeon is trying to manipulate the bone. We also worry about hardware failure. If a surgeon puts a screw into the bone, we worry if the bone is soft, the screw may pull out. We also worry about patients having spine fusion. We worry that there could be a fracture above or below the area of spine fusion. And what's becoming more common as more people have total hip and total knee replacements, if you fall, you can develop a fracture near where the implant ends, and that's called a periprosthetic fracture. And all of these complications can be devastating and can set the recovery back for a patient who's having an orthopedic procedure. So we're here to excite you tonight to take the initiative in your bone health preoperatively by speaking with your surgeon before you have an orthopedic procedure to see what you can do to improve your bone health. We're going to start with Dr. Serota discussing who is at risk for osteoporosis.
Hi, everyone. Well, in broad strokes, women are more at risk than men, although men are at risk as well. Older people more than younger. Age is a huge contributor to fracture risk. Those with a small frame who are slight, thin-boned. Caucasian and Asian women are at the highest risk. It's lower in Black and Hispanic populations, but not absent. Family history is a big one. The genetic hammer falls. So if mom or dad or siblings have osteoporosis, it's something to think about for yourself as well. And there are diseases, conditions, and medications that can contribute to, cause, or worsen osteoporosis. Autoimmune disorders, inflammatory disorders like rheumatoid arthritis, gastrointestinal disorders, either systemic like celiac or inflammatory bowel disease, or anatomic, like if you've had weight loss surgery. There are both cancer and cancer treatments can contribute, endocrine hormonal disorders, diabetes, hyperparathyroidism, if you went through menopause before the age of 40, or have low testosterone in men. There are blood disorders, neurologic disorders, as well as sort of a host of other infectious or inflammatory disorders that can contribute. And then the medications that we use for many of these, like steroids, anti-seizure medications, chemotherapy, proton pump inhibitors. The list is long, and all of these things, for all of these things, the final common pathway can be the skeleton.
Thank you, Dr. Serota. We're going to ask Betty Chow to now discuss perhaps a physical therapy evaluation before surgery and the value of that. And we refer to that as a prehab evaluation. Betty?
Sure. Hi. Yes. So prehab is a formal physical therapist to a physical therapist before you have surgery, and some people will really benefit from this, particularly individuals who have difficulty with mobility at home right now. And other people who will benefit are people who are undergoing surgeries that have surgical precautions to movement or weight bearing. And also the type of surgery and where you have the surgery is also important to factor if you will need formal physical therapy before your surgery. And from my experience, examples of surgeries that are a bit more challenging and where you may want to see a physical therapist beforehand are any surgeries involving the foot and ankle, where you may be non-weight bearing or very limited weight bearing. Also surgeries of the shoulder and elbow, where you will have a sling and you will not be able to have use of one arm. And also spinal surgeries that are more complex, where they may put hardware and do a fusion. And people undergoing total hip replacement surgery, where there are definitely restrictions to certain movements after surgery. And so when you have your physical therapy session before surgery, the physical therapist most likely will try to help identify which walking aids you might need and practice with you, especially if you're non-weight bearing. It's not a great idea to do non-weight bearing for the first time after surgery with medications and lines in you. And also they can also practice bed mobility with you. It's pretty uncomfortable to try to move in bed after you've had surgery, and you're not going to know until you've actually experienced this. Or as a physical therapist, I've seen people have surgery and have a very difficult time moving in bed, and also practice transferring in and out of bed, and also stairs and steps that you may have at home. And they may just give you exercises that are really tailored to the strength and range of motion that you need to be able to move well after surgery. And it probably should entail just 1 or 2 visits. I do want to say that if you do have osteoporosis, you do want to be cautious about bending forwards at the spine. So definitely exercises like sit-ups or anything that's curling at the spine you want to avoid.
Thank you, Betty. Now we'll ask Dr. Stein to discuss what is an appropriate evaluation for patients preoperatively to try and assess their bone health.
Thanks. Hi, everybody. So we really, as Dr. Russell said, we really want to know as much as we can before surgery about our patient's bones, so that the surgeons have the best idea going in about what they'll encounter, and also so that we can possibly do things when we need to, if we find something that could be optimized. So there are several ways that we can look at the bone and the activity of the cells that are in the bone that build bone and break it down, and the different hormones that affect bone. So most commonly, we like to check a vitamin D level. That's just a blood test, and it can tell us if you maybe aren't getting enough vitamin D, and that's an easy thing that we can address. We like to check calcium and the electrolytes, and then depending on what the doctor discusses with each individual person, there may be other tests that are appropriate based on their history. And then the test that we do for imaging that's really widely done, that gives us a pretty good sense of the bone strength and risk of fragility, is called a DEXA, or a bone density test. And it measures how much mineral is in bone. We do it at 3 standard sites. We measure at the spine, at the wrist, and at the hip. And we can use those, usually we use it to diagnose osteoporosis, but we're learning more and more that those measurements and some other measurements that we can do in research do help us understand who might be at higher risk after surgery. And so it's very helpful for our whole team, because we work together here, the rheumatologist, the endocrinologists, and the surgeons, and we really try to all lend our different expertise in together figuring out what we can do to best optimize the patient. So if we have our bone density test and our labs, we can really try to get a good sense going in for what we might encounter. And then there are a few tests that we do in research that help us get an even better look at what the insides of the bones might might look like, but those are a little more specialized that we're trying to investigate now. But the classic and common assessment are the blood tests and the bone density.
Thank you. And Dr. Serota, maybe you could comment on the importance of diet prior to surgery and what patients may want to consider.
So you want to, and this is recommendation always, I always say, do what your mother told you to do. You want to make sure that you're eating the rainbow. I like people to get their nutrients at the farm, not the pharmacy, so that you're eating, I have a colorful plate with lots of nutrients that you do get if you tolerate them. Dairy products, milk, cheese, yogurt. I will go to the mattresses with the cardiologist about that dairy is not the devil. Particularly fermented dairy foods like yogurt and kefir, so that you're getting protein, you're getting calcium, as well as other macro and micronutrients. And you want to make sure that going into surgery, you are at a healthy weight, not to be too heavy, but certainly not to be too thin either. Surgery is a catabolic event and you need calories to heal. If you're not able to get enough calcium in your diet, then we do recommend supplementation of calcium and vitamin D supplementation. Almost every one of us who live above the 37th parallel do need to supplement vitamin D at least part of the year. And something that we don't talk about as much or haven't spoken about as much is protein intake. Protein intake, we probably need more protein as we age. Between the recommendations is 0.8 to 1 gram per kilogram of body weight per day. And if you use an app like MyFitnessPal or something, oftentimes you'll see that you're really not meeting those protein goals. And that's really important, particularly pre and post-op as you're trying to heal.
And I'll just add that protein is important both for bone health, but it's also very important for healing at the surgical incision and wound healing. So we do like patients to get enough protein before all surgery, including orthopedic surgery. We'll transition now to the postoperative phase. Let's hope you had a successful surgery and now you want to get back to the activities that are important to you. Betty Chow will comment on how best to do this.
Sure. So after surgery, most orthopedics will prescribe physical therapy. The time when you'll start physical therapy will vary depending on the surgery and depending on the surgeon. And you as the patient at this point will also know what your surgical precautions are in terms of movement or weight-bearing restrictions. I think at this point, my main concern with patients are really doing too much. Okay, so if you're not in formal physical therapy and your surgeon says, you know what, you can just do as much as you like. And so not everyone they may not know what's too much and what's too little. So these are some of the tips that I want to tell you. So if you're using an assistive device, whether it's a cane or walker or crutches, if the doctor says you can come off them, okay, it's a weaning process. So don't just throw it away overnight. Okay, your body's just not designed to handle that type of stress that quickly. So it's a weaning process. So I kind of say, you know what, wean off by use it 25% less. And then I give them the 3-day rule. See how you feel for 3 days. If you're okay, then wean another 25%. So it's a gradual progression. Also, if you're limping, then you must use an assistive device. Limping means your body is not tolerating it. Your muscle's not tolerating it, or you may just have soreness and pain. Also factor in, you need a balance of rest and activity. So many people believe that, oh, if I rest, I'm regressing. No, your body needs rest. Okay, I run marathons, and in my training schedule, there is a rest day there. Your body needs rest. So you're not running a marathon, but you're just recovering from surgery. So you have to be mindful of that. Think about rest within a day and also between days. Okay, so factor that in. And also monitor signs of overactivity. And the typical signs of overactivity is if you have more swelling than usual, more pain or discomfort than usual and more tightness or limited range of motion that you haven't noticed before. Okay, you need to, once you have that, back off a few days, okay, and then start again. If your activity is walking, you can also use a walking app to monitor yourself and how many steps you've done, and kind of use that as a guide, as a baseline. And also, when you're at the stage where you can start physical therapy, really the physical therapist is there to train your body to return to your functional level or activity level, whatever that may be. It could be that you need to go back and to work and commute by subway. You want to walk 3 miles, you need enough strength to care for your grandchildren. So the program should really be tailored to your activity level, and you need enough strength, range of motion, flexibility, balance, and endurance to accomplish that. And if you have osteoporosis, we definitely will do weight-bearing exercises as well.
Thank you, Betty. And maybe if we have time at the end, we'll come back to what is a weight-bearing exercise. I wanted to now bring up a popular topic. Let's say you were evaluated preoperatively, and now you know that you do have osteoporosis, and now you're going to have either maybe a spine fusion surgery or a total hip replacement or a revision joint replacement. What are the medicines that you might consider preoperatively if you know that you have osteoporosis preoperatively? And Dr. Stein will begin to tackle this topic.
So I would first begin by saying that all of the medicines that we use have to be used in conjunction with all of the things that Dr. Serota mentioned in terms of getting adequate calcium and vitamin D and protein and nutrition and exercise. So they don't replace each other at all. In fact, they complement each other and they require each other to be effective. In the bone, we think of the bones as these solid structures, but actually they're full of living cells, and the cells have different jobs. So some of the cells build bone and some of the cells break down bone. And our medicines work for the patients who have osteoporosis by balancing the activity of the bone building and the bone breakdown. Often as you get older, you break down much more quickly than you're building, and you get out of balance and you end up with a loss. And so the medicines can work in different ways. Most of the medicines that we have slow the rate of bone loss, and that ends up actually fostering the building of new bone. Patients often say, well, these medicines might not build bone. It's true, but you have bone building cells in your bone that then can fill in the holes that have been made and just catch up. And so you can rebalance, and overall that will make the bones stronger. And we think that the stronger the bones are, the better they will anchor any hardware and hold it and keep it where it's supposed to be and stable. So we think that's a very helpful thing. Some of the medicines that we have actually stimulate the bone building cells, so they speed up their activity, and that also can be helpful in terms of building up the new bone, and especially in certain surgeries where there's maybe a lot of hardware, or our spine patients where it's quite complicated. Sometimes we will prefer those medications, but it's an individual decision that depends on many factors related to the patient and related to the surgery. So we like to do the evaluation. As I said, we like to do it as early as possible, but even when we see the patients after surgery, we can do a lot if needed to help to strengthen the bone and to keep things progressing well.
Thank you. I think now we'll start by looking at some of the questions in the chat, and then we can bring up additional topics at the end if we have time. So one question is, how much of a negative impact is being obese when it comes to bone health? So that's question one. And then how much does resistance training help bone health? So, Emily, do you want to comment on obesity and osteoporosis?
Sure. So it's a little bit complicated. For years, we actually thought that obesity protected bone because if we just look at our bone density, which is just how much minerals are in a certain area, it tends to be normal or even above normal in patients who are heavier. However, we now know that when we look at the quality of the bone, so the bone density is how much bone is there, but there are a lot of different factors that make up what we call bone quality. So it's how good is the bone that is there. And that also plays a really important role in terms of the overall strength. So having obesity actually interferes with your bone quality. And that has to do with many things, including the fat cells in the bone marrow. And so we know that that actually now is a harmful, like Dr. Serota said, being on either side of the weight spectrum is actually less ideal for bone. And so having a normal weight is definitely better. If you lose weight, it's very important to do that with a proper nutrition and calcium and exercise, because that also protects the bones from then some changes that can happen actually with the weight loss.
Thank you. And Betty, maybe you can tackle these two questions. How much does resistance training help bone health? And maybe you can also comment on what weight-bearing exercises actually are.
Sure. So in terms of resistance training and bone health, I always advise my patients to say that you can't rely on exercise alone if you're looking for a change in your DEXA score. It's really a comprehensive approach that you need to think about, including diet or medication advised by your doctor. However, resistance training, okay, when you're using a weight for resistance or a resistive band, the muscle is pulling on bone, and bone does react to that force. So there is benefit onto the bone, but I try to let them know that you're not doing that only to get a change in your DEXA score. Okay, there's other benefits for resistance training, which is making your muscles stronger. Stronger muscles, you're going to need stronger muscles for balance. You're going to need stronger muscles to give your muscles a better bulk. Bulk can also be in some ways padding your bone. And you need muscle strength for endurance, okay, being able to be conditioned and doing endurance activities. So resistance training is definitely part of the type of exercise that you would need if you have osteoporosis. Now, weight-bearing exercise, everyone talks about weight-bearing exercise if you have osteoporosis or low bone health. And I think the best way to think about weight-bearing exercise is gravity. Okay, if there is gravity on the bone, then that's a weight-bearing exercise. So depending on different positions and different bones, okay, you can have, obviously walking is a weight-bearing exercise for your legs, but it's not a weight-bearing exercise for your arms, okay? So sometimes if we want to have weight-bearing exercise for the arms, we'll put people in what we call kind of a tabletop position, so they're weight-bearing through their arms. And if you think about the spine, sometimes just a sitting position with good posture, you're actually having gravity through your spine. So that position, it's good for the spine. The other comment I always hear is, oh, I don't want to swim because it's not a weight-bearing exercise. Well, swimming is a great conditioning exercise. You shouldn't throw that out just because it's not weight-bearing. You do need conditioning and aerobic exercise as well if you want a comprehensive exercise program to target osteoporosis.
Thank you. Maybe Dr. Serota or Betty could comment. Someone comments that they have a pelvic prolapse and osteoporosis, and they're wondering, are there exercises they can do having a prolapse?
I'll take this one, Betty, and maybe you can add in. I mean, certainly anything where you're sort of increasing the pressure, a Valsalva maneuver, like the kind of when you sneeze or have a poop, where you increase the intra-abdominal pressure can make the prolapse worse. However, exercises, there are, pelvic floor physical therapy exercises to strengthen the pelvic floor, to raise the pelvic floor muscles, tighten the pelvic floor muscles that are helpful for prolapse, and you can still do resistance exercises, pumping iron, as Betty said. It's, weight bearing doesn't necessarily mean you're, Arnold Schwarzenegger pumping iron. You can use bands, you can use springs, you can use, Pilates, gyrotonics, things where you have a more stable core with less, intra-abdominal pressure, but you're still really getting at those muscles and resisting those muscles. So, nothing's off the table. And it's just something that you work together with your exercise professional, your doctors, your physical therapist.
Great, thank you. I'll take one question. I've had a spinal fusion 7 years ago, and now I have osteoporosis. Will the screws fall out? So I would say in that instance, it's just important to treat your osteoporosis. Thankfully, you are being monitored. Thankfully, it was diagnosed. And once you have osteoporosis, or if you have osteopenia and an elevated FRAX score, which is a way we kind of assess the risk of fracture, most recommend treatment of osteoporosis. So I think it's just important to monitor and to treat if you do have osteoporosis. If anybody wants to add any other comments. Maybe this is a question for Dr. Stein, as Dr. Stein is doing a research project in this area. How effective is TYMLOS in helping new bone growth after spine fusion? And how much improvement can you expect?
So I share that question. I think, it's really important to think about this, and all of these medicines have been approved to treat patients who have osteoporosis. So they haven't been approved to treat and improve bone after surgery. That's not saying they don't. It's just saying that we don't have all of the data necessary to know that yet. So we are doing, as Dr. Russell said, a study right now, testing TYMLOS to see whether it does improve the healing after spine fusion and to what extent. So, hopefully we'll get that information pretty soon, but it's an area that I think we here at HSS are, one of the best places to really lead, because we have such a volume of surgery, and we do work together so well in our complementary teams. And so we are working on that. So maybe the next webinar you can ask again, and we'll give you a better answer.
The next question is interesting and timely, and I'll open it up to the panel. Are you seeing adverse effects on bone health in patients using weight loss injectable medications? Anybody want to tackle that? I mean, yeah.
When we lose weight, we lose bone. However, we lose weight. 10 pounds can be a standard deviation change in your T-scores. And certainly this accelerated loss that people are having from a lot of the newer injectable medications is we're going to start to see profound bone loss, as well as muscle loss. You lose muscle as well, which is one of my concerns with these medications. And a lot of these medications, they work by making you less hungry, nauseated even. And so your intake is strongly curtailed. And then that time when you feel like eating, what's the quality of the food that you're taking in, right? You may be losing weight and feeling healthier because you're losing weight, but how you're fueling yourself may be inadequate. It may not even be possible to get as many macro and micronutrients in that limited time frame. So I think we're just seeing the tip of the iceberg. And that's not to say that, these medications don't have a role and a place, but I think there are a lot of unintended consequences as well.
There are a couple of questions that are very patient specific. So we won't go into specific details, but I'll try to be broad with the question that's asked. So one speaks to a hip replacement that failed. And this person also has rheumatoid arthritis, which we know is a risk factor for osteoporosis. There's been a revision. There'll be a revision. And should I take an osteoporosis medication before surgery? So that's the perfect example of before surgery, absolutely wanting to speak with your surgeon about your bone health. And at times, if there is a concern about poor bone health, you may want to begin a medication that builds bone for a significant period before that surgery is attempted. And that's really where working with a physician that specializes in bone health, along with the surgeon, you're planning the surgeon, just like you're planning which piece of implant you're going to use, you're planning how to improve the bone quality. I think we've done a pretty good job on questions. Just looking, let me just go to the chat. I was in the Q&A. Same question about injectable bone loss medications. And there's a question about Boniva. So I guess I would comment, and others can, when patients ask about specific medications, it's a bit difficult to speak to that because it really depends on the patient and their comorbidities and what's suggested. But for a medication to be FDA approved in the United States for the treatment of osteoporosis, there had to be a study that showed that it reduced the risk of fracture. So all medications that are FDA approved in the United States are beneficial for bone health. Let's see. Okay, let me just see if there are any new questions. I think we're good. Okay, so I would like to take time to summarize what we've spoken about tonight. I think we've discussed the value of a preoperative bone health assessment preoperatively, and also the consideration for a prehab evaluation to improve function. We've discussed focusing on diet, namely calcium, vitamin D, and protein preoperatively to try to enhance healing, and postoperatively to have a robust physical therapy program. And throughout this process to see if you do have poor bone health, are you a candidate for medication? I thank you very much. And I think Claudia is going to just talk to you for a few minutes about her closing remarks.